Hello and welcome once again to Minds That Matter. My name is James Thomas. I'm your host today. And we have a very special guest. We have the Director of Behavioral Health, Developmental Disabilities in Hospitals, Mr. Craig Stenning. Craig.
Nice to be here.
Good to have you here. The first thing is we've got a new name.
We do.
Yeah. When did this all come about and how did it come about?
Well, actually several other directors had tried to change the name, to remove the R word from the name. As you know, the old name of the department was the Department of Mental Health, Retardation, and Hospitals. And I was very pleased that I was the director that was successful in getting this name change through the General Assembly and signed by the governor. He actually signed the bill in June of this year. It became official in July. And then through a number of different activities, we actually had a formal ceremony at our department in September of this past year, at which the governor was present, several members of the General Assembly, the sponsors of the bill, and the leadership of the General Assembly, both the Senate and the House. And in particular, and what I was most pleased about, was the fact that we had several hundred individuals at the ceremony, individuals with disabilities, who were so happy that we finally were able to remove the R word. This has been a campaign that actually we had great support from both Special Olympics, from organizations such as Advocates in Action and PAL, to get behind the movement to get this bill actually through.
That's great. That's great. You're right. There's a lot of stigma attached to the notion of retardation.
There is. I mean, some people tried to downplay, well, we were just changing a few words around, but we have found out, and I've seen it in my own family situation, and we see it every day at work, that words are really important. And stigma, I just came back from a conference, a mental health conference, talking about doing away with using the word, talking about stigma all the time, because just talking about it sort of reinforces the notion that there is something different that we need to overcome, and that we need to emphasize the positive rather than the negative. But certainly the stigma attached to that word is one that's very damaging. I had situations where children were coming home hearing that word used against them at school and not wanting to go back to school. We had a speaker from Special Olympics who talked about the fact that when she was in middle school, she had heard that word used, whispered behind her back. And she's a quite eloquent, vibrant young woman that is a ambassador for Special Olympics throughout the world. But she reflected back upon several years previous that she had heard that word used. So I'm actually thrilled that we were able to change it. I'm hoping that we'll move forward, maybe even with a different name, and as the years go forward, to talk about a more positive way of looking at what this department does.
Well, you've also changed the first name too. You changed it from mental health to behavioral health. And I know that you were the originator of CODAC, correct?
I was. I spent 28 years as the director of a substance abuse treatment agency that actually went through the years when we separated mental health and substance abuse. We merged those into one, and then several years later, I was asked to become the first executive director of behavioral health, and that was a movement to merge mental health and substance abuse.
Right.
Because unfortunately, we used to have these silos, and a lot of it was based upon the budget. It was based upon the way the federal government divided the budget up, and they still do, unfortunately. But we really need to look at people as a whole, and there's very few people that come in to any of our systems of care with just one type of disability, either substance abuse, mental health, or even developmental disabilities.
Correct.
One of the advantages, going back probably 5 or 6 years ago, I was asked as the executive director of behavioral health if I would become the acting director also of developmental disabilities. It was supposed to be for 3 months. It lasted about 4 years. But during that time, we saw so many cases where somebody was coming in with a developmental disability, but they were also experiencing some type of behavioral disability as well. And in the old days, there was a lot of finger pointing.
Right.
You know, they're not going to do well in our system. They belong in the other system. So when I was director of both, I said to the staff, we can't point the finger at each other anymore. We have to figure out a way to make the services available to an individual based upon what their needs were, not based upon which door they came through or where most of the funding came from. We need to do away with the, I'm sure you've seen it in your own career, in which we looked at, well, which was the predominant disability?
Right.
You know, was it more mental health? Was it more developmental disability? Was it more substance abuse?
Right.
Well, they can't be seen here because we need to detox them first. So hopefully, little by little, as we train staff better, and as individuals do better assessments, you know, we're getting away from that part of the work.
Well, we used to have folks that would come, wherever they came in is where they stayed. And it was very difficult to get them elsewhere. If they came in with a developmental disability but had behaviors that were such that someone said they must be mentally ill, they ended up at Eleanor Slater Hospital, and then they couldn't get any DD services because they weren't eligible because they had already been in the mental health system. So once you got in the system, you stayed in the system, which was difficult.
It was difficult, and it's wrong for many reasons. Number one, it's not the proper treatment, support, or care that we need to give to individuals. Number two, individuals with disabilities have the same civil rights that all of us have. They have the right to due process. They have the right to be seen in the setting that is most appropriate for them. And we've talked a lot in the past several years in reforming our system throughout the department to make sure that people receive, as you know, the right level of service at the right time in their life and in the right setting. So it shouldn't be determined by whether or not you come into any particular door. It shouldn't be determined about, you know, who your advocate is or who your lawyer is. It really should be about who you are as Jim or Craig or Mary or Jane.
Right. Well, we had one woman that came to us that had a long history of developmental disabilities, and her family, when they did an initial assessment way back when, said that they thought that she had a developmental disability, and the parents were outraged by that. My daughter's not retarded. You're not going to put her in that system. And she ended up in the mental health system and didn't get the care that she probably would have gotten if she had stayed in the developmental disability system. So it's she never even got into the developmental disability system.
Two things about that. Number one, we do need to do more cross-training so that you could be in one system or the other and still get services.
Right.
We had a couple of programs 2 years ago where we did cross-training so that if somebody was actually in more of a need for a setting where they fit in a mental health group home, for example,
right,
but yet also be trained on what types of communication skills you need to deal with somebody who may have a mild developmental disability.
Right.
Because the way you approach that person, you know, needs to be somewhat different.
It could also be what kind of day activity do they need, too.
Correct.
It could be that they may need to go to a workshop setting for day activity, but they could live in a mental health group home.
Well, I'm a great believer as we move the system forward that we need to really look at those issues more than the label of which disability it is.
Right.
I'm reminded, you mentioned the parents were outraged. When I first became the director of the Division of Behavioral Health, I did a series of focus groups. And I went out to about 40 different places. We called it the Magical Mystery Tour. And it was a way for me to talk directly to people. And I insisted that we had consumers, that we had staff, and we had board members present. I wouldn't go unless we had all three in the room. And I was shocked and disappointed by the fact that people talked about the stigma of the other side of the street. So when I visited a substance abuse facility, I had a couple of parents say, well, at least my son or daughter is doing something that they can change. They just made a bad choice. At least they're not crazy. And then within an hour, I visited a mental health facility, and I had a couple of parents there, and they said, well, at least I'm glad that my son or daughter, you know, has a mental illness, because that's something that they can't do anything about. At least they're not an addict, and they use terms other than addict
right,
to describe that as well. And I was really disappointed by that because it was like, well, you know, we're better than they are at least. And that's not what this is all about. This is really about individuals that need some type of support. And I think the other way of moving away from those stigmas is to really look at what it is that we're talking about when we talk about support. Because when I was growing up in the field, and the years that I spent as a treatment provider, we talked about treatment as this, almost as this magical period in someone's life that you enter into treatment and your treatment is completed, or you go through episodes of treatment, and somehow that was going to change everything that you're doing. And when I've come to realize, and hopefully the field has come to realize, that treatment is only one aspect of what needs to happen in your life. Because for treatment to take hold, we really need to look at recovery. Or in the DD world, because we don't talk about recovery in the same way, although I do, we need to really look at the support system. Because for me, the definition of recovery is not being defined by your disability or your illness. You're not seen as an individual who's disabled or who's ill. You're seen as an individual, period. So what do we need to do to get there? We need to provide housing. We need to provide employment. We need to provide social skills. We need to provide coping skills. We need to provide all the supports that you and I have in order to exist. I was talking one day to an individual at lunch in our hospital, because one of the other aspects, as you know, of our department is that we run the Ellen Slater Hospital, which has been lively these days with a few issues last week with some repairs that were being done in the hospital. But as I was talking to this gentleman, I said, so hopefully in a few months you'll be leaving the hospital. What is it that you'd like to see in your life in order to make that meaningful? And he looked at me and he said, well, I'd like to have a job. I'd like to have a decent place to live. And I'd like to have a date on Saturday night. And you know, at first I chuckled. We could probably work on the first two. I'm not so sure about our ability to be a dating service. But what that really meant was, I'd like to have people in my life who care for me, people that love me, people that support me. And in some ways, that's what agencies and that's what support staff do. They provide that type of love and concern and caring on a Saturday night. But we also need to look at housing. We also need to look at employment. You mentioned day activities. That's where our focus needs to be. It's not just providing a place for people during the day. It's providing the skills that they can then move on to some type of less supported environment during the daytime and during the evening hours.
I've